Hey guys, welcome back to my channel. I'm Muriel, this As Told by Muriel. Just wanted to come make a quick little video. Let's talk about long-term care. I said I was going to return because of the case that's going on in Pennsylvania. Well, it's no longer a case. I believe the nurse has already been charged and convicted for, I believe it was negligence. I'm not exactly sure what the charge was, but basically there was a patient who had several falls in the facility over the course of a week, and the patient had a fall on this nurse's shift, and she falsified documentation for her neuro checks. For those of you who work in long-term care, you will be familiar with the process of recording a fall. When a patient falls and it's unwitnessed, we always have to do neuro checks because the patient may or may not have hit their head, and there may be some intracranial bleeding or swelling that we can't see on the outside, but we can do assessments because it is a neuro assessment. We can do assessments that can kind of let us know that something may be going on with the patient. It'll come across in their level of consciousness, sometimes in their cognition, their pupil response, meaning that the pupil may or may not constrict when a pen light, or when I do it, normally I use my light off of my cell phone, my flashlight, when their pupils does not constrict. Also in their range of motion, there may be some dysfunction in their range of motion on the way their ability to move their hands, their legs, versus how they were at their baseline. On their posturing, you learn about decerebrate and decorticate, I believe it is, position. I can't really pronounce it, y'all. This southern drawl of mine is something with those quarter and, but anywho, decorticate and decerebrate, saying those, but anywho. So this nurse, she basically falsified the documentation. Also with neurochecks, we're supposed to get vital signs. It's on a certain time frame. And if you go back to my fall video, it'll jog your memory of what I said you have to do when you're faced with a patient who has an unwitnessed fall. This nurse was charged, and we found out that this nurse was over the care of 37 residents at the time, which, y'all, that is very common, especially on night shift. I've heard that it happens on some nurses on day shift. I absolutely refuse to take care of more than 25 patients on day shift. I'll say 25 patients depending on their acuity, but I absolutely, 25 is usually my limit. I will not take care of more than 25 patients on day shift in a long-term care facility. The reason they give so many in long-term care is because these patients are supposed to be of very low acuity as far as acute illnesses. They all have chronic illnesses, and these chronic illnesses are what more than likely led them to having to have long-term care placement. But as far as acute illnesses, they're not supposed to be in this type of facility with acute illnesses. When something acute occurs, this is when we send them out to the emergency room, or for evaluation, or we have labs done. There are some things we can treat in-house, like infections. There are some infections that can be treated in-house through oral antibiotics. I have done fluid replacement, as far as just like fluid replacement, not electrolyte replacement. I've never done electrolyte replacement in a long-term care facility. When you're receiving electrolyte replacement, you really need to be monitored, and you need your electrolyte levels checked, specifically your calcium, your potassium, your magnesium, your sodium, and also your phosphorus. I don't know if phosphorus is actually considered electrolyte, but we do check phosphorus levels as well. If you're needing that type of replacement, you really need to be in the acute care setting. But anyway, there's been a lot of talk that the nurse should have not been working with that many patients. She should have refused to take care of the patient. And now there's this big talk about the staffing ratios for nurse versus patient ratio in long-term care. I don't know why this is all of a sudden a new discussion. The ratios have been ridiculous forever. I remember when I first became a nurse, and when I went to work in the long-term care, I was working the floor because I didn't know any better. I was a new nurse. I came from a medical surgical unit in the hospital because that's where I originally started as an LPN, and I went to long-term care, and I would work a floor that had 40 patients, day shift. I didn't know any better. I know I was all out of, once I learned about pharmacy recommendations and things like that, and had given meds an hour before and an hour after, I was all out of scope, not out of scope, but I was all out of the time frame for medication, because there's no way you can give 40 patients their medications in basically 2 hours, because that's all you have, 2 hours. There was no way to do it. And so as time went on, they decreased the ratio. Like that hall that had 44 patients, they would work 2 nurses on daytime, but still only 1 nurse at night, which 1 nurse at night, depending on the acuity of the patients, that's still a lot. So yeah, I completely understand. But nurses, we have to, when we're working, we have to take in our capabilities, what we can do and what we can't do when we take on these assignments. I have refused assignments before. I've refused to take keys and count narcotics with an off-going nurse if it's going to put me to where I would have like 30, 40 patients. I've refused to take the keys. And yeah, it could be at the detriment of me possibly losing my job, but it won't be at the detriment of me losing my license. Yeah, because I know I wasn't capable of taking care of that many patients, especially on day shift. Day shift, you know, you got meals to get through, you got doctor visits, you got dialysis. They go to dialysis. You got the bulk of the meds are given on day shift. Plus, you have tube feeders, which a tube feeder, the level of acuity on a tube feeder is higher than the level of acuity on, say, a patient who just take their meds PO. The level of acuity on a patient with a trach is higher than the level of acuity of a tube feeder. Now imagine having a patient who has a trach and a tube feeding mixed in with your other 30 something. Like, you have to protect, when they say protect your license, you have to protect your license. I've been faced with several situations where I've had to send a patient out because of a fall, because I felt like, okay, say my patient fell 8 o'clock at night. There's no way x-ray is going to be out there to, and I feel like they probably fractured something. Although we can do in-house x-rays, there was no way an x-ray can be done in-house before, say, 4 to 5 hours. So I would, go ahead and call the doctor, but I would let that doctor know, I believe this patient has a fracture. All signs are pointing to a possible fracture, whether it be pain, the positioning of their body when they're observed on the floor, and I have that patient sent out. Now, say if this same patient happens to fall at, say this patient falls at 10 o'clock in the morning and the body is in position, but I suspect there may be a fracture, but it's 10 o'clock in the morning. The chances of me getting someone out there to do a x-ray is fairly high. I can get someone out there to come and do the x-ray within a few hours. I'll call the doctor and I'll have them, see if we can get some pain medication ordered so I can treat the patient for pain, but I will have the x-ray done in-house. Now, if it comes back and the patient does have a fracture, then we will have them sent out. Okay, when it comes to a fall with possible head injury. So you didn't witness the patient falling, but you don't know if they hit their head or not. So when you go to do their neural assessments, if the patient's pupil isn't reactive to light, like it's not constricting when you put the light in, and that's not their baseline, they probably have some type of neurological damage. If the patient mobility, like they were full range of motion prior to the fall, and now they are not able to, say, move extremity, or not able to grip when they were able to grip before, more than likely there's some either bone, some type of a fracture going on, or that could be due to neurological damage from hitting the head. Say the patient was alert following the fall, and then they started becoming drowsy and in and out of consciousness, or anything with their level of consciousness, they probably have a head injury. Say the patient had a head injury, it's a little laceration, but they're alert, they're oriented, but you notice the patient is on Plavix, they're on aspirin, they're on Coumadin. We have some patients who take heparin, like the patient is on a blood thinner. More than likely, I would go ahead and send that patient out just to be on the safe side, especially if the patient has a history of a CVA. I would more than likely just encourage, you can call some doctors, and 9 times out of 10 they'll be in agreement with you on sending that patient out. It's the facility who's sometimes not in agreement, like your director of nursing. I've had a director of nursing come up to me and be like, why did you send that patient out? And the patient didn't have a fall, but they were complaining of chest pains. We went through the 3 doses of nitroglycerin sublingual tablets. They were still complaining of chest pain. This patient had a cardiac history. And so I called the on-call, but I didn't notify the director of nursing. Now, for some reason, I don't know why she felt like she was, I'm not gonna say she was ahead of the doctor, but the facility census was pretty low. This was during the time, of this panoramic or whatever we calling it. And the census was low, and, sending patients out, they really try to discourage you from sending a patient out. But, excuse me, Miss Ma'am, this patient is a full cold. He's complained of chest pain. It's not being relieved by the nitroglycerin tabs. Yeah, he has to go out. I'm sorry. And also, I've already contacted, I can't remember if it was the nurse practitioner or the doctor, and they were fine with them going out. So she came to me and she was like, well, you were supposed to call me. And then, excuse me, Miss Ma'am, I notified the doctor. The doctor gave the okay to send them out. Yeah, I'll probably get around to notifying you, but you're not my priority at this time. You're not the priority for me to make that notification to you, that you weren't the priority at the time. My priority was getting this patient sent out. And so, there'll be some pushback when it comes to sending a patient out. But you as a nurse, you know what your capabilities are in a facility and what they aren't. Now, okay, this is something like a totally different circumstance, but I've had a patient before who was having vaginal bleeding. Now, I was not aware that the patient had that vaginal bleeding prior to, but towards the end of my shift, the patient had vaginal bleeding. And so I notified the doctor, and we did get an order for a CBC. I wasn't told of any vaginal bleeding prior to this. Well, another nurse came on like the next day. I didn't work the next day, but the patient continued to bleed throughout the next shift. And so the next day, another nurse came on, and the patient appeared very pale. I don't know if the CBC results were back or not, but no, yeah, the CBC came back. I think the patient hemoglobin was like a 6.5 or something like that. Well, come to find out, the techs told her, not techs, because I was in a long-term care facility, that the patient had been bleeding and that they had made other nurses aware. There was nothing in this patient's documentation when I worked with her. Mind you, I worked that facility, but I didn't work that floor often. But I did work that facility, PRN. And so the techs, who are, techs, they know about they know about their patients. Like, let me tell you, they know their patients. They said they had been telling the nurses that the patient had vaginal bleeding and no one had done anything about it. Okay. Had I known that this patient had this vaginal bleeding going on for however long prior to, I probably would have. I mean, the doctor did what they did by getting the CBC, and according to the CBC, that's what got the patient sent out. The patient actually had to end up having, I think, like 2 units of packed red blood cells. But when I when I gave the doctor report, had I known the patient had been bleeding like for days, I would have told them, well, it's not documented, but the techs are reporting to me that this patient's been bleeding for a while, and the patient appears pale in color. I would have notified them of all that, and the doctor probably would have sent that patient out on me, not let it go on for, not let it because they didn't allow it, but it wouldn't have went on for the next over the next course of 24 hours until the CBC results came back. It wouldn't have gone on that long. So yeah, so that's just some of the things I want to say. But working in the long-term care is not